I'm just going to go through a few preliminary slides and then we will turn it over to our guest speakers today. You're going to hear from the leads for pillars 3 and 4 from our national network, who will be speaking about the priorities and current work that they have been progressing within their pillars of research. And without further ado, we will start with a land acknowledgement. We wish to acknowledge this land on which the long COVID web operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we're grateful to have the opportunity to work on this land. Just a reminder of the purpose of these webinars. It's to share evidence-based information, research results that are relevant for decision makers, researchers, clinicians, patients and families, and the general public. To provide ongoing updates, spotlights on emerging evidence and scientific information about the activities of our national network, and to contribute to reducing and managing misinformation about long COVID. We do have a code of conduct that you can find at this link, but also on our website, which essentially says we value highly engagement around the science and its interpretation, as well as its application. A commitment to reasoned discourse, as stated in our code of conduct, comes with a responsibility for all of us to ensure that any comments or questions remain within the spirit of positive, constructive, and respectful discussion. So we welcome any or all questions and comments in this spirit. Thank you. The cameras and mics are off, but sorry, just flip back there. Please do post your questions in the chat. We will pause for Q&A after each pillar speaker. So we have after pillar 3 and then after pillar 4. And we'll do our best to review and address as many questions as we can. The sessions are recorded, and your attendance assumes consent to recording, and with permission from the speakers, this will be posted online following the webinar. And we do welcome your thoughts about how these sessions could be most helpful to you. We have a very short feedback survey, which will be posted during the webinar. I just encourage as many as you can to please just take a few minutes to do that. So thank you. This is the feedback survey, but we will put it into the chat. And I will just turn to our pillar 3 speakers now. Pillar 3 is all about health services research. And we have Drs. Kieran, Quinn and Naveed, Janjua, who will speak to us about their activities in their work. So thank you. I think it's to Kieran first.
Thanks, Susan. Good afternoon, everyone. And from those calling on the West Coast, good morning. My name's Kieran Quinn. I'm a clinician scientist at Sinai Health in Toronto. And I practice general internal medicine and palliative care along with the clinical research that I do. It's really my honor to be here today to present to you about the work that Naveed and I and the Pillar 3 have been working on. And so I'm going to start by talking about the development of a national data atlas, and Naveed will build on that and how we use this information to advance our knowledge and improving care for people with long COVID. Just briefly, I don't have any formal conflicts of interest to disclose, but I do receive research funding for this work, which is to pay for the research costs, not my salary, through CIHR, and the Long COVID Web, which is also funded by CIHR. So the challenge that we face now is that we really don't have a good understanding of the long-term healthcare needs, the types of healthcare and how frequently people with long COVID need healthcare. And the latest estimates from our national surveys, which were completed in August of 2023, so more than a year old now, are that 2.1 million adults in Canada are living with long COVID. And that probably is an underestimate, and we see these numbers continuing to rise year by year. And so without an understanding of these healthcare use patterns and the needs of people with long COVID, it makes it very challenging for us to understand how to improve care and plan for the future care of these individuals. One of the main reasons that we are not able to study this at a national and population level is we don't actually have methods to be able to know who has long COVID within our administrative data. Administrative data is health data that is routinely collected as part of people's interaction with the healthcare system. And that data is securely held and de-identified or made anonymous so that we're able to study individuals without actually knowing who those people are. And furthermore, beyond that lack of ways to identify these individuals, we also have limited measures around a lot of the really important things that affect people's health. Their socio-demographic factors, so maybe their age, their sex, their ethnicity, their gender, and then a bunch of other clinical factors that may contribute to their healthcare needs. So with that in mind, we had 3 objectives for this particular study that we've done as phase 1, let's call it, of our Pillar 3 work. And first and foremost was to develop what we call a national atlas, which is going to outline and describe all of the available data to us that we can use to study and improve care for people with long COVID. And the whole hope of doing this is to be able to identify an accurate way to identify people in administrative data with long COVID. And that's what Naveed's going to talk about after this. We also wanted to look at, outside of the administrative data, what are the other cohorts, so groups of people that have been studied with long COVID across Canada. We often work in silos, and the whole point of this national network is to bring us together to collaborate and accelerate our understanding and our research. But we need to know what's out there and who's working on this so that we can achieve those goals. And lastly, each province and territory have different data sets, and we need to understand what are the data sets that are similar enough that we can use across different provinces and territories to study people with long COVID, to achieve this larger goal, as I said, of improving care and planning for health system resource needs. So this is just a flow chart that we presented as part of the initial proposal and the different phases of our work. So what I'm presenting to you here is the red box, sort of the phase 1, where we're developing and constructing this national data atlas. Naveed and our teams have together figured out these different consensus algorithms, so these methods to identify folks, and really there wasn't any available to us prior to developing a new one. And then lastly, which we're actively involved in now, is trying to what's called validate these methods to identify people. So you create a tool and a method, and then you need to show that it's accurate in a slightly different way. And that's what we're doing now with some of these cohorts that we've studied across Canada. We can use those to test the accuracy of the algorithm that Naveed and his teams have developed. So how do we go about doing a data atlas? Well, we do something called a comprehensive environmental scan, which is a fancy way of saying we look under every rock and contact every person that we know or that we might know or that somebody else knows that might be studying or have data that gives us the ability to study long COVID. So we surveyed all of these different individuals. We looked in the literature, and we did a whole bunch of different types of Google searching. And we did that between last August and November. And then over the past several months, past year actually now, we've analyzed and collated all that data and are moving it forward now. In addition to that, there's a relatively new service in Canada called the Health Data Research Network, HDRN, and they are trying to harmonize all of these provincial and territorial data sets that are administrative data at the population level, similar to what we were describing about harmonizing the individual measures within those sets. So we took advantage in partnership with them and worked to figure out what assets in the data we have to be able to support our work. And this is the sort of the main result of our environmental scan to figure out who is studying people with long COVID and what data is available across Canada. So you see a map of Canada here with the different provinces and territories. The color coding legend is up here in the top right. The orange circles mean that these cohorts are continuing to recruit people and study them, so they're growing over time. The green ones have set out to recruit a certain number of people, and they've done that, and now that that study is finished. And then there was a couple cohorts we couldn't actually figure out, and the people weren't reporting to us whether they were done or ongoing. So those are the two in the gray boxes there. The size of the circle corresponds to the number of people within their data set. And those are from 1 to 1,000, 1,000 to 10,000, 10,000 to 100,000, and in some cases larger than 100,000. The little font text over on the right is all of the different centers that are studying these cohorts and the size of their study cohort in the box there, just for people's awareness. But overall, we found 19 different studies of people with long COVID across Canada, mainly in Quebec, Ontario, Alberta, and BC. And then when we looked at what type of data were these cohorts studying and collecting on people, so we know what we're able to work with. All of them are collecting data on age. Almost all of them look at whether a person is a male or a female. The majority, which is actually quite impressive, are collecting information on self-reported gender as a man, woman, or LGBTQ plus genders. Then there's socioeconomic status, ethnicity, and race. And you can see that as we move into the more difficult measures to actually collect routinely or even prospectively, we see less and less of these cohorts collecting these types of information, which help us understand some of the really important elements about a person. Now, when we're looking at the administrative data across the different provinces and territories, there are 9 provinces and territories that were able to harmonize their data, and it's available to us to be able to study. And then these are the different, on the y-axis here in the text, the different types of measures that are available within those. So whether it's how many times people are hospitalized, if people are alive or if they've died, etc. And then the numbers here show you the percentage of those data sets that have that measure available. So the least available information is whether people actually were vaccinated or not within a particular province. Less than half of the provinces or territories collected information on that, but up to other measures, as you can see before you. So the takeaway from all of this, it seems like it's a small amount of work to present in a few slides, but it was an enormous effort and led by one of my outstanding students, Aisha, who I think might be on this call here today. And it's really the first atlas at a national level to help people understand what is available to us to help study and improve care for people with long COVID. And there's more than 500,000 individuals in these data sets. So it's a really powerful way, I think, for us to come together, work together to accelerate our knowledge and help. It turns out Canada as a nation, we have a very rich repository of these data sets. But as is known in many other studies, some of these data sets are limited by first how they actually defined long COVID, because different people are using different definitions. And we really didn't feel that there was sufficient measures for a lot of these equity-related things around gender and race and other measures. If we take those lessons and we make a recommendation that if we come together and create a set of standards, something called a minimum data set, that anybody studying long COVID in the future should abide by and should collect these types of data, it will allow us to work even better and combine these data sets over time to, again, achieve our goal of improving care and developing health policy to plan for the care needed in the future. So the other lessons that we've learned are that we have a lot of provinces, unfortunately no territories, that have population level data. So that will help us study individuals when we develop this algorithm that Naveed's going to talk about to understand care and improve care. And it will really accelerate and launch our ability to do future research when this is nearing completion now. And the next phase is a really exciting phase where we get to use these tools to do the work that we set out to do a couple years ago now. This particular work for the Data Atlas, Aisha and our team has submitted to the Canadian Journal of Public Health, and they're currently reviewing it for publication, and we look forward to their decision on that. So with that, I'm going to just thank you all for your attention for this. We can hold questions maybe till the end, and then Naveed can tell you how we're building on this work and the work that his team has done. And then we're happy to answer questions about this all. Thank you so much. And Naveed, over to you.
Thank you, Kieran. Just checking if I'm sharing the correct slide. Okay, that's good. Thank you, Kieran, for setting the stage and providing update. I'm Naveed Janjua. I'm based at BC Center for Disease Control in University of British Columbia, and I will talk about the algorithm that we are developing for identification of long COVID patients in healthcare administrative data sets. I would like to start with the acknowledgement that this work is carried out and I live and work on the traditional, ancestral, and unceded territories of Coast Salish people, Musqueam, Squamish, and Tsleil-Waututh nations who have cared for these lands for time immemorial. I would not go into the details of why these algorithms are needed. Kieran has explained it very well. But what I would say is that we developed an algorithm previously, and over the past year, we have been working to refine that algorithm, and that's what I will talk about in next few slides. And for these algorithms, we used a data set or a platform that we are calling it as a BC COVID-19 cohort. This cohort was established as part of COVID response, where all provincial healthcare utilization and registries are linked with COVID-19 datasets, including COVID testing, hospitalization, vaccination, and all other COVID-related data sets. So that covers entire population of British Columbia, and it includes individuals who have not been tested for COVID and those who have been tested for COVID. And that is important because we know that during the later stage of pandemic, testing was available only to selected individuals based on disease severity. And that is where we need to look at individuals who have not been tested through the PCR test, but may have COVID symptoms or may have developed COVID. And that is part of the algorithm development and the validation work that we will be doing in future. So how we approach this problem. So for these algorithms, when we develop, so we compare individuals who are so-called gold standard. And in this case, gold standard was people who were diagnosed clinically in long COVID clinics in British Columbia. And we compared these individuals with subset of individuals who tested positive for COVID, and we we deemed them that they do not have long COVID. And then we applied a machine learning regression model and build multitudes of different models looking at various characteristics. And we selected a model that had optimal characteristics in terms of its performance. And I will talk about some of these performance characteristics in the next few slides. And then this algorithm was applied to the entire population of individuals who were diagnosed with COVID or had a positive COVID-19 test. And that identified individuals who could potentially have long COVID in healthcare administrative data sets. For this exercise, we looked at pre-existing conditions, and then we looked at symptoms and conditions that were present at the time of acute disease, as well as socioeconomic status and demographic and geographic variables. And when we developed this model, the original model that we developed with large number of variables, that had a sensitivity and specificity of both 86% each and area under the curve as 93%. So these measures are how good the model is, and higher this, better the model is. And when we worked with partners, including review of these variables with clinicians like Kieran and some of our other colleagues, as well as application of statistical techniques to reduce the number of variables, we were able to bring it down to 57 variables in the model. And that while keeping the performance of model close to its original model, and as you could see that the performance here is 85% sensitivity, 86% specificity, and the same area under the curve. And when we applied this model to the overall number of individuals who were available, about 283,000 adults, this resulted in about 45,000 individuals being identified with long COVID. That results in about 16% individuals in British Columbia. So what were the characteristics? So this is a busy table and the same like next slide, but I wanted to bring this up to highlight how that the entire cohort of people who tested positive for COVID looked like, and how that was distributed, how these characteristics were distributed among individuals who were diagnosed in clinics, and then how model performed in terms of predicting these individuals. And we could see that the overall age, and here we are presenting age and sex, they were similar in between the clinical cohort as well as the predicted long COVID patients. But when we compare it with the overall people who tested positive for COVID, people with long COVID were those greater than 40 years of age, being female, and with comorbidities that I will show in the next slide. So this is again like a very busy slide, but the key message from this slide is people who were either clinically diagnosed with long COVID or who potentially had long COVID based on the predictive model have much higher pre-existing conditions, whether these are asthma, diabetes, or others, and they have more severe disease at the acute stage, required hospitalization or ICU admission. Just to summarize, this model that we have developed has a very good performance. When we look at the other clinical models or the data in the field, it identified about 16% of people diagnosed with potentially with COVID-19, and people living with long COVID are more likely to be ages greater than 40 years of age, female, have more comorbidities, and those with severe acute disease requiring hospitalization. So in terms of next steps, so the model documentation and other pieces are currently being finalized, and the plan is to apply it in other provinces. We are already working with Kieran's team in Ontario, where we are applying this model in Ontario datasets, and that will help us to learn how we could expand and extend it to other provinces, and that will help us provide the picture of long COVID across Canada. So I will stop here, and thank you very much for your attention.
That's terrific. Thank you very much, Kieran and Naveed. I just wonder if either of you wanted to speak to the questions that, thank you, Kieran, you've answered a couple of them there. So about the importance of diagnosis as a pin in helping to move a lot of this work forward, and also the importance of listening to patients along the way to help inform what you're doing, and also as another important source of information there. Anything else you wanted to add to those, Kieran or Naveed?
I would just add to Jane, Miss Colwell's last reply. I'm not entirely sure what they're looking for as far as groups in Ontario, but there is the Long Haulers group is the nation's largest online community of people living with long COVID, and I'm told from a lot of my patients that it's helpful for some to share experiences and sort of validate the frustrations and identify hope and priorities for the future with fellow people with lived experience. So I hope that answers your question, and thank you for it.
So I could add some more to that. So the work that we are doing, and this is really key. So these are data sets which do not have the level of details that we would like to have. So that is where clinical context as well as individual patient context and the details are very important. That's where we have our patient partners who reviewed some of these variables that we included and suggested some additional variables. And when we did this exercise with our clinical partners, some additional variables that they were seeing or characteristics and symptoms that they were seeing in the clinics were suggested, and we tested these variables in the models, and that's how these models were refined. Same thing that we are doing with our patient partners as well. And some of the other exercises or the studies that we are doing is looking at subgroups of patients or characterization of subgroup of patients based on symptoms. And again, that work is also happening in collaboration with patient partners. We are also collecting some survey data from patients. So that is in collaboration with patient partners, and also collecting additional details so that could help us interpret and overcome some of the limitations of healthcare administrative data sets. So that survey work is ongoing. And as Kieran highlighted, that one of the problem with a lot of these data sets is like we may not have some important characteristics, such as socioeconomic status or ethnicity. And that is where we are making effort to collaborate with various racialized communities to collect data so that there is a broader representation of people across Canada, so that we have these algorithms which are useful and applicable everywhere.
Great, thank you. Just a couple of comments. We have posted the link there to the trusted resources in response to the questions about support at national and provincial local levels. So the links are all in there, and you might find other resources that might be helpful to you. Secondly, there was a question about if the slides will be available. The recording of this session will be available after the session is finished in the next couple of days, so it can be reviewed at any time after that. And I think there's another question here from James. It's important to identify risk factors that increase the likelihood of getting long COVID. Is there more responsibility than usual to couch that in terms of emphasizing nobody is without risk, given the current climate in public health, government, society, holding ableist beliefs and messaging that minimize risk of COVID broadly? Any thoughts on that statement and question?
Yeah, that is a very important point. The risk for COVID is very broad. So for long COVID is very broad. And that is what the studies are working to characterize. And as you see that we are looking at some of these factors, and the way these studies look at, they compare individuals with long COVID with those who do not have long COVID based on these definitions. And we should realize that the even definitions aspects are sometimes not that concrete, and now we have much better handle on some of these clinical definitions. But at the end of the day, we identify some of the characteristics, and that helps to provide care as well as other services and supports as well. But that does not mean that it's minimizing the risk at the population level.
Great, thanks. I might just ask one more question myself, just about how you're connecting with decision makers with the results of this work, and how it might influence potentially in future the availability of resources to support people living with long COVID.
Do you want to go ahead, Naveed, or do you want me to respond?
I could start and you could. So there are multiple levels at which we are connecting with decision makers. So some of this work is funded through Public Health Agency of Canada, and we have regular meetings with them in terms of updating them on where we are with respect to progress of this and that. It's very useful avenue, because idea is that once we have these algorithms developed, they will become part of the broader repository of definitions that are available across Canada. So that is one aspect. But then, of course, like the other results are being shared through various channels and avenues to provincial as well as national policymakers. I'm based at the Center for Disease Control and connected with some of the health system partners. Through that, I'm able to share. And same Kieran in Ontario. So Kieran could talk about that, but we share these results on regular basis with the health system partners so that these are applied as soon as we could.
Yeah, I will just say very briefly in Ontario, I've briefed the Ministry of Health and the Ministry of the one that is responsible for long-term disability. So it's called the MCCSS, Ministry of Childcare and Social Services. So we directly briefed the minister in charge when she was still the minister at that time on long COVID and the experiences of people with long COVID and the challenges that they face, especially those living with disability or trying to get disability insurance. And I've done several different sessions with the adjudicators for long-term disability in Ontario to advocate and help them understand the episodic nature of long COVID so that it's helped them improve their adjudication process, which is different than other types of disability. And the Ministry of Health, myself and several of my colleagues have briefed them and continue to work with them and advocate to plan for future needs. So we certainly do engage with health policymakers and decision makers. That's one of the primary goals of our work, is to change health policy to get people the supports that they need.
Excellent. Thank you very much. I'll just allow this one last question here, which is, does the administrative database allow you to have prevalence data for children and adolescents?
I'll let Naveed take that because he's the expert in the algorithms.
Yeah, I was writing my response, but so right now we don't have algorithms in place, but this is also part of the work that we are doing, and we are working to develop that. We could apply the same algorithm that we have for adults, but ideally we would like to develop algorithm that is specific to children and adolescents, and that's what we are working on. And that will help us to come up with prevalence as well as other care-related characteristics as well.
Terrific. Well, thank you very much, Drs. Quinn and Janjua. That was just terrific, excellent, clear presentations. Much appreciated. And as I mentioned before, this session is being recorded and will be available shortly after we finish today. So we'll turn now.
Sorry, I'm just going to say thank you all. I have to leave, but thank you for the excellent questions as well. That's really great to see the engagement.
And thank you. Thanks, Kieran. So we'll turn now to pillar 4, which is our population health research pillar, and Dr. Andrea Gruneir, who will talk to us about the work they've been doing there from University of Alberta. Thanks. Over to you.
Thanks so much. Thank you for having me. So I just want to first start off by saying that I'm joining from Quebec City today, which is the ancestral lands of the Wendat people, the Innu people, and the Abenaki people. But like you said, I myself am from the University of Alberta, and actually this project, this pillar work is led out of Saskatchewan, all of which is on Treaty 6 and Métis homeland territory. So I also want to say I'm here on behalf of a much larger group today. Sorry, everyone. Okay, I'm figuring it out. I'm here on behalf of a much larger group today, and that there are a number of acknowledgements, of course, that we want to make. Of course, the Long COVID Web, the Saskatchewan Centre for Patient-Oriented Research, which has put in some amazing resources to help this work move forward. The pillar is in part led by Gary Groot, and he's really been the lead on all of this work, along with Katrina Mazurek, who has just done an immense amount of work to actually ensure that this continues to move forward. This is a really large team with a mix of experience and expertise who've worked on this. And it's kind of been split up into 3 different groups. The working group members, who are sort of like the people doing the day-to-day grudge work of all of this. And then the steering and advising group members who've helped to shape different elements of the work as we've moved through it. So for today, for our short time together, I'm really going to just focus on reminding everyone what Pillar 4 aims, the creation of the long COVID minimum data set, or MDS. And this actually very much ties into what Kieran was just mentioning in his in his presentation of the Pillar 3 work, and then a little bit about some of the upcoming and planned work that goes along with this. So Pillar 4, as a reminder to everyone, really focused around population health. So what is it that we could understand about the extent to which we see people living with long COVID within the population and some of their related needs? And there were two main aims, I think you could call them, that were affiliated with Pillar 4. And I'm going to focus on the first one today. This was around the facilitation of the creation of a national registry of people living with long COVID. And that would be used to incorporate core data elements on the long COVID experience, as well as potentially support research across all long COVID web pillars. So the goal was that ideally we could identify a way that we could capture people across the country living with long COVID and collect some basic information, and that those people would be able to contribute to other research as they wanted to and to continue to inform it. The second aim was around understanding the economic impact of long COVID across Canada, and that part is being led by Ellen Rafferty. I'm not going to touch on that part today because it's quite separate from this, both in sort of content and expertise. So just a little bit of background. Everybody here knows there's been such a rapid increase in research on long COVID. And it's new, it's an emerging condition. Lots of stuff is coming out every day about it. The major challenge has been that despite this huge amount of research that's coming up, there's actually been relatively little consistency across studies in terms of what they're capturing it and how they're capturing it. And this was somewhat the case, regardless of the kind of research we were talking about, whether we were talking about treatments, we were talking about the lived experience or other elements, including health service use. So there was an effort in some of the COVID community to create what they would have called a core outcome set or a core set of outcome measures alongside it for clinical trials related to long COVID. So what that really means is that this is a group of individuals who worked together and said, okay, if you're going to be doing a trial that's going to be testing some intervention or treatment for long COVID, these are the things you should be measuring, and this is how you should be measuring them for the outcomes. So the goal was to encourage the studies to ensure their outcomes were more comparable to one another. The challenge, though, for those of us who work in the population health sphere is that not everything they look at is fully applicable to us, nor do they actually capture all of the interests that people within the population health world might have. So that led to the specific objectives that I'm going to talk a little bit about today. And this was to build a minimum data set, or what I might call an MDS in some cases, which would be used by a core set, which would have a core set of common measures for a potential registry that would broadly capture the long COVID experience. So you can see there's a bit of tension already in this statement. We want a core set, a minimum core set, but that's also going to broadly capture the long COVID experience. So there is some tension that we're going to need to work around. And you're going to hear a little bit more as I get into this, what that means. And we identified that there were several places that there would be an interest. So of course, there's information about the symptom and disease trajectory, the types and the quality of care that people receive, and then of course, the kinds of treatment that people use and the way they experience the outcomes of those treatment outside of a trial environment. So what happens when people are in their own homes, in their own lives, taking them. And for anybody who is not familiar with the concept of an MDS or a minimum data set, it's really a set of essential core measures, but it's not necessarily fully comprehensive. And we can come back and discuss that a little bit more later. So to do this work, there were two main phases to the methods. The first was an environmental scan, and Kieran also referred to an environmental scan in the Pillar 3 work, but basically what we did, what the working group members did, was they took a very broad open look at the literature that was out there, as well as the other research that was going on related to sort of the population level interests of long COVID to see, okay, what are those studies that are finished or ongoing? What is it that they're actually measuring with respect to the long COVID experience? And then from there, we use that to inform what's known as a Delphi process. So Adelphi is a way of trying to obtain consensus from a panel of experts using a set of iterative surveys where you encourage people to come to some level of agreement on what are the priorities or the key issues under study. I'll walk you through a little bit more exactly what the Adelphi look like in this case, and I can certainly answer some more questions about this as well. But just keep in mind that the most important thing of Adelphi is that you're working with experts to try to get them to come to some level of agreement about what is most important or most critical to an issue. And we use the environmental scan to set the stage for the first survey of the Adelphi process. Now, the first survey that was presented to the steering and the advisory committee had 635 questions on it, and it was like 65 pages long. This was obviously a no-go. This was not going to work. Many of us recognized it from the beginning, but this is basically meant to show you actually how many research studies there are out there and how broad the questions are. And even in some cases where questions were similar, but not similar enough to group them as a single question, some of the things we were running into. So let me just tell you then, the working group, again, led by Katrina, did an immense amount of work to weed through those 635 survey questions and work it down into some more core concepts as opposed to specifically phrased items and specifically phrased response sets, because that's part of what was creating the confusion there. And so they took a survey that was 26 pages that required participants to make 635 decisions and whittled it down to 6 pages and to make 243 decisions, which is still a lot. It's still a lot. But typically, the first round of a Adelphi survey is still fairly intensive because you are getting people to kind of work through everything that's out there to get into the most important things. Sorry, I always have trouble flipping slides. Okay, so in order to identify people who were interested in participating in the long COVID Adelphi process, we reached out to members of the long COVID web using the newsletter, using website. We sent anybody who we knew a request to just share it with their friends and their family and their colleagues, anybody that they knew that might be interested. And basically the eligibility criteria were pretty brief. We just wanted people who had some either lived or professional expertise with long COVID. So this is very open to anybody living with long COVID, anybody caring for somebody with long COVID in either a clinical or a more personal capacity, researchers, and even decision makers. So anybody who had an interest and some professional experience or personal lived experience with long COVID is what we were interested in. About 52 people participated in the first survey, and actually about 52 people continued to participate through all 3 surveys. So we were really glad to see that we had retention across the 3 waves. This is a bit of a breakdown of who participated. So the single largest group are people who were living with long COVID. And then that was followed by people who were caregivers or family members to people living with long COVID. And then we had various levels of engagement with clinicians and researchers, and a little bit as well with community leaders, which was really interesting to see. The only people who we really didn't get any engagement from were policy or decision makers. I'm not sure, to be honest with you, how that might have affected the outcomes, but we can certainly discuss that further. So as I mentioned, there were 3 rounds of the survey. So the first survey is the one that I provided a little bit of information on, where I showed you it was about a 30-minute questionnaire, and there were 240 something decisions for people to make. And the purpose of the first survey was really to get people to start to eliminate the things that were falling out in terms of importance, because not everything received the same level of consensus for how important things were together. Once we got the results of the first survey, the working group then took that and created a new survey that much more focused on those areas where people agreed this was something that we should keep in a survey. And then they went through a process of prioritizing the topics in the second survey. So each survey basically kind of builds from the one prior to it. And then the third survey really focused on verifying what people had said from the first and the second surveys in terms of getting to really this core set of what there was agreement on, what should be considered a core minimum data set in terms of long COVID data collection. Also say that in addition to having people pick from things that were already existing, there were always opportunities for individuals to write in things that they thought were missing that were really important. And this was picked up a few times. So there were some cases where this was integrated and moved forward, and other places not, sort of again, depending on the priority that it was giving as we moved through the different waves of the survey. And all the participants were the same participants. So we didn't have new individuals participating, right? So they were seeing it again and further commenting based on what they had seen. So as I mentioned, we started with the environmental scan, 635 survey questions. We moved to the first survey, which was whittled down to 247 questions. From the responses to that, we got the second survey, which was 197 questions, and then 34 questions from the third survey. And that leaves us with 48 questions that were identified as sort of the core minimum data set. And this worked out really nicely because actually the goal had been no more than 50 questions in a minimum data set. And I realized that even saying 50 questions in minimum data set doesn't totally work together. So what did we hear about as being the consensus items for a minimum data set? So these are sort of roughly grouped into three main categories: care, what was the experience of primary care, specialty long COVID care, rehab and other supports, the quality of that care, as well as barriers to access and facilitators to access for different forms of care. There was a lot of discussion about things related to quality of life, including daily activities, ability to engage in paid work, coping abilities, fears for recovery, quality of life, and conversational ability. And then, of course, many things related to symptoms that people are experiencing: respiratory symptoms, cardiovascular symptoms, dizziness, brain fog, fatigue, and then post-cognitive and post-physical exertion. And then the last column in this table shows you the time periods that people thought were really important to capture in this kind of minimum data set, because we need to put some kind of time frame around all of these questions in order to understand what they apply to. So in some cases, people were talking about prior to having a COVID diagnosis of any kind. Sometimes it was within the 3 months post-infection, and sometimes it was more current. So there was also a need to situate all of these experience timing-wise relative to sort of the current state, as well as around the time of the original acute infection. So what's next? Well, one thing that's not on the slide, I should mention that Katrina and team have really been working very hard to put a manuscript together so that that can be submitted for publication, and looking at other sort of traditional academic strategies so that we can ensure that we share this. But the other piece is that we want to ensure that we identify ways to engage with broad communities, as well as people who are looking to or are currently modifying the way they collect data related to long COVID. Because like we said, ideally what we would love to see is a community of researchers around long COVID, wherever they may be, collecting comparable data that we can then use to have sort of a broader understanding of what's happening. In addition, there's some complementary research that's going on. Two studies in particular that I want to highlight. One is a study that's going to be led by Naveed Muhajirin, who's also part of this work, and as well based in Saskatchewan, which is looking at the association between chronic conditions and long COVID symptoms that's modified by vaccine status. And for this work, we'll be using data that's collected by Stats Canada. And then the other is a new study that was also recently funded that Gary Groot and a resident that he worked with, Nicole Labine, will be leading in the Northwest Territories, which is looking at the experience of long COVID within the Métis Nation there. And so that's a very exciting new piece of research as well. So I'm happy to answer any questions I can here. And I'll stop sharing so I can see the screen.
Thanks very much, Andrea. That's terrific. There's a question from Louis. Has the CDE parameters used in the field of MECFS been considered as part of your environmental scan, or will it be used as part of your selection of data elements? Just in terms of the synergy in the data recommended for both conditions, there might be some usefulness there due to overlap.
Thank you. Actually, that's a great question. I'll be honest with you, I don't know off the top of my head. I think I'd have to go back and take a look. I know as an environmental scan is generally a pretty big net that's thrown out to try to see what's out there, but I don't know to what extent ME was considered within that. I would have to go back and check.
Okay, and there's another question there about the about pain and whether or not that was in your symptoms list.
Yes, pain was in it. I hope it was in that little table that I put together. If not, it should have been. Pain was certainly one of the elements that came up.
Okay, and Donna just noted that chronic fatigue is included in the MDS, so that's very helpful.
Fatigue as well.
Good. I know you said we could go back and discuss a couple of things. Is there anything you would like to pick up on that you felt you didn't have enough time to talk about?
Only if it would be helpful for people to better understand the work. I guess I can link it back to the notion of the registry, because that is raised as one of the aims of Pillar 4, but doesn't really come through, I think, at the end when we talk about how this work was done. So the notion of having a national registry actually kind of predated some of the discussions around the long COVID web, in some early discussions between Saskatchewan and Alberta, a little bit in BC, and to some extent Manitoba about, can we do like a Western kind of registry to capture this? To be honest with you, at this point in time, it's been sort of hard to see some traction with the registry just yet. It doesn't mean I think we've dropped it by any means, but the idea of ensuring that we can really well promote this core minimum data set, I think, is very appealing at this point in time, because it would help to ensure that even people who are collecting data that may not be interested in any kind of registry or be more challenging to connect to it, that they may be able to collect some comparable data so that we can have more consistency in our understanding of the long COVID experience. Oh yeah, I see somebody asking about an app. Yeah, so there has been some discussion about an app and the ability to use that to monitor symptoms. And in fact, one of the very early discussions that we had when it was still kind of a Western province kind of discussion, there was app discussion at that point. To be honest with you, I'm not sure where that went ultimately in that conversation. It seemed that there was keenness about the app amongst some people who are participating in that early conversation and less keenness amongst others. So I'm not sure what the future holds for that, but I think that's a great idea, because some of the thinking around it had been not just a one-time collection of this, but really understanding it from a trajectory experience for people living with long COVID web. And not long COVID web, long COVID, excuse me.
I do know that there are some online resources as well where people are asked to input their data. So I don't know if those could be a source in the future as well, such as the Citizen Science website that collects information about long COVID. And I believe there's something in BC going on about self-reported data. So I think there could be some interesting resources there. Yeah. Good. There was another question here about, well, just about engagement. Perhaps we'll bring back in Naveed as well, because just curious about the engagement from the Atlantic provinces. I know that when we were building our trusted resources at the time, there were no clinics that were listed in the Atlantic, other than there's a new one though that Dr. Chung has just mentioned in the chat there. But is there engagement from the Atlantic, and do you see wide variation, I guess, across the country in terms of engagement for initiatives around long COVID data?
So with respect to data, the Atlantic provinces do have healthcare administrative data sets, and as we described, we are still in the process of finalizing these algorithms, and then these could be applied across Canada. Right now, we are working with Ontario team, but once we apply it in Ontario, then it could be applied in other provinces as well. As Kieran showed, that the data sets are available across Canada. We haven't looked at territories, but across all provinces, data sets are available. It's just a matter of applying these algorithms and then assessing prevalence and characteristics.
Great, thanks. And there's a question about the testing for COVID. I know that there are a number of data points around symptoms, but can either of you talk about sort of the testing and the state of diagnostic tools and analyses that can be done for long COVID?
I'm not aware about any specific test that could be used. So I'm not sure if Angela or others are aware of that. At least I'm not aware about a specific test that could be used to diagnose long COVID.
Yeah, I'm sorry, I can't answer that any better.
That's okay. I think that Dr. Chung is online. I wonder if, Angela, are you able to speak to that?
Sorry, I was dealing with something else.
That's okay. It was a question about testing for COVID and the kind of, if we're talking about registries and minimum data sets, is there anything in the future, for instance, around any promise for a test for COVID?
It's unclear. Right now, like the government funded, at least in Ontario, the government funded testing kits are gone. And so people are resolving to buying testing kits from like pharmacies and stuff like that. So, you know, I know that there are people working on testing, have like one test for flu, RSV, and COVID, which would be great because they're all respiratory viruses. But I haven't really seen it in practice yet.
And nothing for long COVID, I presume.
Yeah, and Andrea sort of talked about sort of, establishing a registry. I think even before we put long COVID web together, we were, I had discussions with Gary about sort of maybe doing registry, and because I think we can do it in Ontario, and he was interested in doing it on the west side, and thought maybe it's possible to do it sort of nationwide. But without funding, none of these things would happen. So it means someone has to put a CIHR grant in. And as it currently stands, it's really tricky in terms of whether it would be funded or not.
That's great. Thank you, Angela. Yeah, that's good. So I'm just looking for, oh, there's a comment here for long COVID. They found some mitochondria markers. Yeah, I think there is some definitely research going on in that area, but nothing conclusive as yet. So Andrea, any comments you would have? The same question I asked Naveed and Kieran about connections with decision makers and progress on thinking about how a registry could influence future services or policy.
Yeah, I think there has been maybe a little less connection with decision makers at this point, in part because the audience for this work has been to encourage researchers to ultimately take up a core set of common measures. And there's been a strong push to try to continue our engagement with people living with long COVID and their caregivers to ensure that they're really able to participate in this work as fully as possible, given the focus. I think as we move forward, we'll be exploring more ways to try to ensure that we can make the intention of the minimum data set as clear as possible and as attractive as possible to others interested in developing any kind of cohort or data collection strategy. The registry piece, although we had some early conversations, as Angela said, and it's kind of dropped off a little bit for now, I think there will still be an interest in trying to understand how we can get that bigger picture of people living with long COVID as best as possible. And maybe there's a potential that we're able to work better with Pillar 3 and their algorithm develop as one strategy for try to identify that. But I don't know that we're in a space for that just yet.
Very helpful. Thanks so much. I think we're at time. It's 2 o'clock. I just want to say a huge thank you to our speakers, Andrea, Naveed, and Kieran. And thanks to all of you for attending today. I wish you all a very safe, healthy, happy holiday period as we come up to that in the next month or so. It's already in the shops, but and we'll see you back in the 3rd Tuesday in January to reconvene for our next series of webinars. Thanks, everyone. And please do fill out the survey if you have a couple minutes. Thanks so much. Take care.